epicardial and endocardial mapping percutaneously to understand the disease process, but also help, hopefully, in the control of the arrhythmia for these patients. So, like I said, in many institutions you might consider lines or going after ganglionic plexi, or and folks that believe in rotors and firm ablation. Or you could argue that this guy's had 4 ablations, he should go to a true surgical maze, and that's not an unreasonable consideration. Because this was the first time he'd be seen in our institution, we offered him 1 ablation. We're not proponents of multiple ablations on our end. If we fail more than about twice, we usually will refer to the surgeons. In this case, though, we thought it might be best to consider mapping the endocardium as well as the endocardium. And we know, obviously, the atrial structures are relatively, compared to the ventricle, where we think, oh, well, we can't ablate transmurally with in VT. In AFib, we always assume it's a relatively thin-walled structure, and we should be able to make transmural lesions, and oftentimes we can, but that's not always the case. Our initial interest in epicardial access for AFib dates back to about 2007, 2008, when we did it in this paper by my partner, Dr. Bush, looking at esophageal protection. And that has been shown by numerous centers. We've always been a little bit conservative with posterior wall ablation. Certainly people like Dr. Natali ablate with higher powers in the posterior wall, obviously moving very quickly. We've been always a little resistant to high powers in the posterior wall, and partly from seeing a few of these esophageal fistulas show up on our doorstep. We've had 2 that I know of that were from our institution, but we've had a number transferred in from other institutions that our surgeons have had to deal with. This is actually a case series that we recently presented showing the surgical techniques to deal with these acutely presenting esophageal fistulas. So in the original description of esophageal protection, we used a peripheral balloon in the pericardial space to protect the posterior wall or the esophagus from ablation on the posterior wall. And in some cases, we've done this in the past where we've failed to provide full PVI because of rising temperatures in the esophagus, and we've brought them back specifically for esophageal protection. And here's a couple images of that. People have obviously used balloons and other techniques for phrenic nerve protection as well in VT. But we believe that getting more information of the posterior wall, which is, I think, an important target in these resistant cases, as shown nicely by Dr. Natali's case today with aggressive posterior wall ablation, can help us better understand if there's regions that we're missing for full transmural lesions. And this shows the nice anatomy from a Kalpin's atlas of that oblique sinus and how we can access the region of the posterior wall. So our technique is largely the same as described by Dr. Sosa and Skenovaka for VT, and which we use today. You can see in the left image the needle, percutaneous needle, in a subxiphoid approach. We typically use a posterior approach for access. The image on the right shows after we've gotten access, doing a pericardiogram to show nice free fluid movement in the pericardium to ensure that we haven't gotten into a cardiac structure prior to putting in the larger sheath. Once we did this, we can then map the left atrium as we typically would with double transeptal access, circular mapping catheter and an ablation catheter. Our technique is typically to use the Agilis sheath for the ablation catheter and a non-steerable sheath for the circular mapping catheter. In this case, we've then placed percutaneously a closely spaced duodec, which is our go-to catheter for VT mapping, both endocardially and epicardially, into the oblique sinus directly across from the endocardial catheters. In this case, despite 4 ablations, we ensured the first step is always PV isolation. So we did full up PV isolation and ensured that we have exit block from all the veins. This is just an example of that. Pacing around the circular mapping catheter to ensure no capture. And then we had some nice electrograms. At the top of the screen, you have the circular mapping catheters, in this case still showing some electrical activity in the posterior wall. And then directly across from that, you have the epicardial mapping catheter, again showing some nice epicardial signals on the posterior wall. And here's another example of that with diminishing endocardial signals. We still have very prominent epicardial signals. Thank you. And I think this image here nicely shows an example from our case series, which is now somewhere in the 10 to 12 range, that when you look at the endocardial map, had you only had endocardial points, you would say the posterior wall is completely isolated and no significant signals are seen. Yet, when you look on the epicardial side, you can see clear in the top right, you can see clear areas of continued normal voltage. In this case, we then put in the pericardial balloon for protection of the esophagus, and ablation here was still endocardial, but we were able to, by more aggressive endocardial ablation with the pericardial balloon protection, then remap and show that those areas of survivor myocardium were now scarred and that we had completely isolated the posterior wall. In addition, in this case, we did renal denervation. We have used this technique for VT and been part of a couple small case series using it for VT, but numerous centers have used it in combination with PVI for AFib. Dr. Steinberg and his group have done a number of these. We've done this selectively in patients that have had refractory hypertension in addition to their difficult to control AFib, using a standard irrigated tip ablation catheter and NAVIX or CARTO mapping of the of the renal arteries. Endpoints are difficult with renal denervation. This is from one of my VT cases, but you can do high frequency stimulation and see a blood pressure rise prior to ablation, and then repeat that high frequency stim and hopefully see no blood pressure rise as a surrogate for a successful RF, though obviously that has numerous limitations. In this case, with the combination of epicardial and endocardial mapping as well as renal denervation, we're now about 8 months out. We do not have a link in place, so obviously all monitoring with AFib is limited, but we do 3, 6, and 9 and 12-month monitors for all of our 2-week monitors for all of our AFib patients, and to date this patient has been AFib free. Thank you.